Well, this Africa, we're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Hi, everybody. Good afternoon, and you're welcome to this webinar. We are excited to have you join us today and hope you are as excited as we are. I see that we are rapidly increasing in numbers. And so I just want to remind you to send out that reminder to the person you invited for this webinar so that they do not miss out, because today we are going to go real. We are going to talk about disclosure issues. And if you are a service provider like myself, I can bet that you have the same issues. So why not just reach out to that person you invited just to make sure that they remember that today is the set date for the webinar. Of course, again, you're welcome to Paediatric Real. And like I said earlier, everything is about to go real. Remember what real means. We are reviewing cases, we are engaging peers, we are assessing experts, and we are learning lessons. And I can assure you that you will have a full package today, because for sure we have the cases, for sure we have our peers that are ready to share their experiences. Of course, we have our experts on the panel, and why not you can use the Q&A box to put in your own opinions as well, because we value your opinions at PATA. And of course, at the end of the day, ultimately, we are going to learn lessons. I am Dr. Vanessa Fozawumbi, country representative for PATA Cameroon.
I believe Dr. Vanessa has internet problem. Maybe perhaps we can continue. Let me just, yes, welcome. I believe everyone can hear me. So as Dr. Vanessa was introducing, we also have experts, and our slide here is showing that PATA REAL is what the meaning of REAL is: reviewing, engaging peers, and also access to experts and learning the lessons. And we're very excited. Can you just move the slide? I'm Dr. Ngapongwa, Filoka Ngapongwa from Tanzania. I'm country representative of PATA here in Tanzania. I'll be an expert as well as just to work with Dr. Vanessa in case there's an internet problem. Yes, so our theme today is navigating disclosure and care in pediatric and adolescent HIV. And with that, and I'll need to welcome our
Dr. Filuka.
Speakers. Yes. Okay, Vanessa, you're here there. Okay, cool.
Thank you. This is how real it can get. I mean, we are in PATA REAL and it can get real, real, real. Thank you, Dr. Filuka, for stepping in. As she has said, our theme for today is navigating disclosure and care in pediatrics and adolescent HIV treatment. There is translation available for our colleagues who are Portuguese speaking and French speaking. You look out for an icon that looks like a globe at the bottom of your screen, and there you have access to translation. For purposes of security, we have had to keep our chat box closed, but you can share your thoughts in the Q&A section. Again, reach out to those you invited so that they can be a part. Thank you. Slide, please. So we are going to, like I said earlier, have our experts who are going to be speaking or giving their input to the cases that our peers have prepared for us. The peers are going to introduce themselves when they are going to start their session. So I would just rapidly say that we have 3 experts that are here to help us navigate these cases and really break it down and bring it and make it as real as it can be. So we have Dr. Filuka, who spoke earlier. We have Prof. Alani, who is also a great expert here to contribute. Thank you, Prof, for always being there, and we are looking forward to your valued contributions. And lastly, we have Robina, who is also there for expert reviews. And I guess I had introduced myself already, so there's no point in doing that again. So thank you. Slide, please. So I'm now going to welcome the first presenter, who is going to walk us through a case that he did. So these are real life experiences. They are not conjured. So I call all of us to stay focused and capture all the lessons that we can. Thank you, Dr. Asong, you have the floor.
Thank you very much, Dr. Fozao, for giving me the floor. I am Dr. Asonlefak Betran. I'm a medical doctor working in the regional hospital annex of Kambe, which is in the northwest region of Cameroon. So I'm going to present to us a case slide. So the case I'm going to present is a 14-year-old girl. She's an orphan and the youngest of 5 children. She's having different biological fathers to her siblings. Both parents passed away when she was 4 years old. She has lived with her maternal grandmother, her aunt and older sister, who are all farmers in various locations pretty far off apart. She was diagnosed of HIV at the age of 7 years. She's the only known person in the household living with HIV, and she's currently in primary 6. Slide. She was born in October 2010. She presented in 2017 with cough, fever, breathing difficulties, and skin rashes. It's interesting to know that she's been having the cough and fever for a couple of months prior to consultation. It was managed with roadside medication. It's only when it became severe that she was rushed to the hospital. So on examination, she had signs of lung consolidation and generalized maculopapular rashes. A number of investigations were done, chest x-ray and full blood count, which confirmed the pneumonia. Sputum analysis was negative for acid-fast bacilli. HIV serology was positive. Potassium hydroxide confirmed the fungal dermatitis. So a diagnosis of severe pneumonia and fungal dermatitis in newly diagnosed HIV-positive patient, stage 2, was made, and she was managed accordingly. So looking at the clinical evaluation from the point of diagnosis to 2017 to 2019, she was initiated on Zidolam nevirapine, and her first viral load copy result was undetectable. And what we did was we did partial disclosure, but also encouraged the caregivers to continue encouraging her to take her medications. In 2020, when she was 10 years old, now on TLD, her viral load copies increased to 501, and we realized that she was struggling with adherence due to lack of a stable caregiver, and she had a lot of uncertainty about the reason for her taking the medication. So we called the caregivers and encouraged them to provide her with a stable location, and also we encouraged them to continue the disclosure process, but they declined to follow this advice. In 2021, when she was 11 years old, the viral load copies increased to 5,000. And the reasons we realized was due to drug fatigue. So she stopped taking the medications, and the caregivers were unaware. So we continued to support the caregivers, and we began EAC. And at this point in time, we did full disclosure. In 2021, that's after the EAC, our viral load copies dropped to 2,929. Now we realized that the child was more adherent, but still had some doubts about her status. And she was asking questions about why her mother passed away while on medications, or why her siblings are not also taking the drug. So although the guideline recommends switching at this point in time, but we looked at the context and decided to extend the EAC. Slide. That same year, after the second session of EAC, the viral load dropped to 2,870 copies. And the reasons that we could get was that she traveled for holidays to a relative who did not know about her status. And so there was lack of follow-up, and she also struggled with adherence at that point in time. So looking at the results alone, we suspected treatment failure, and switching to second line was recommended. But after deliberations and counseling reinforced, we decided to reinforce counseling and adopt the DOT approach to her follow-up. In 2022, when she was 12 years old, the viral copies dropped to 620 copies. We continued the counseling and placed her on adolescent pairing, so that we have some form of a mentorship with an adolescent who have gone through the same process before. From 2022 to present, her viral load copies are undetectable, and as a result and as a booster to her, she was made an adolescent champion. Slide. So the lessons we learned first with a success story was that we had a very strong post-disclosure care, which helped the child go through the process. The child is also an adolescent champion, and she's presently helping other children living with HIV go through the process of adherence. The lessons we learned is that if the disclosure process is not started on time, or if it's done accidentally, as in our case, the decision on switching has to take into account the context of the clients rather than on our usual guidelines and protocols. There are a lot of patients, or we need a lot of patience when we are managing or following up children living with HIV. And for proper disclosure to really is essential. Proper disclosure is essential to ensure that retention and viral suppression of children living with HIV is ensured. And caregivers play a crucial role in the management of children less than 10 years, especially if they cooperate among themselves. Slide. So the questions I have for our expert panelists is that first, for children with multiple caregivers, what strategies can we use to start the process of disclosure? Secondly, in the case of accidental or on-the-spot disclosure, What advice will you give for us to proceed? Finally, is there a clearly defined guideline for accidental disclosure? We know about the guidelines for disclosure as a whole, but for the accidental disclosure, is there a specific guideline or is there an avenue for us to get one? So thank you very much, and over to you, Dr. Fuzao.
Thank you very much, Dr. Assom, for that. At this point, I'm going to be calling on Professor Alani and wonderful Dr. Filuka to provide some elements of responses to these questions that he has posed. And of course, I'm calling on our audience. You can make use of the Q&A just to make your comments and inputs as well. Thank you, and over to Dr. Filuka.
Thank you so much. Thank you for the presenter. This is a very good example case, and I like that this client ended up becoming a champion in supporting the others, and the fact that the facility or the team have tried their best to even call the caregivers and educate and give them advice, but unfortunately, perhaps maybe they needed more advice and ended up declining the management of the patient. But eventually, this patient ended up becoming the champion. So with the first question, with the multiple caregiver, the strategies is at first we need to identify who is the main caregiver for the child, and this should start early, not even from the beginning. That when the patient becomes diagnosed with HIV, and start understand who will be the main caregiver, and also at that time we start to give the even the counseling to the caregivers and the as well as doing the family conference so that they can select one person who will take care of the child and the other can support. And another strategy is to involve the social welfare so that they can also navigate and do assessment as well as from the facility, even in the community. And also in addition to that, the use of community health workers as well as the peer supporters, which we can see how our child has improved when they meet peer-to-peer and talk about things. And then perhaps in that group, they realize that this is not my own problem. Even others have a similar problem and they can support each other. So, and additionally, I understand most of our country, we are lacking the psychosocial part of the the services in our facilities, and also the team, which ideally needs to have that the clinician, social welfare, either psychologist or anyone expert with the psychosocial, as well as so that when the child comes in, can get all that at one stop, and then even being evaluated. For example, this child has been diagnosed, is an orphan, so there's all the red sign as an orphan, as well as being that at age of 7, understanding that HIV positive, living in a family where there's is the only person who is known with HIV, and the fact that he's been having multiple caregiver who really not engaging much with the child. So with that, has a lot to take, and it also has a lot to. That's why he has so many questions, because he doesn't have anyone to talk to. So this is the kind of patient who we can start at the beginning to give a peer supporter or even the community health workers. Sorry, I know the time, but there's more to talk about this, and I can allow Professor to continue, but yeah, we can continue this discussion about the accidental disclosure and how to do it. Vanessa, because I can see you.
Thank you very
You are
much,
warning.
Hilud.
Yeah.
Okay, thank you for those elements of response. And I would just call Prof. Alani to supplement or to add on to what you started saying and build on to that. Thank you, Prof.
Thank you very much for having me. Well, I think I have to congratulate the clinic that managed this adolescent. They did a wonderful job to the extent that the patient eventually became a viral load champion. That was great. I want to say that what you have seen reflects what we know, that antiretroviral drugs work, except you don't swallow them. And when you swallow this drug, because we know, particularly the dolutegravir containing regimen, these are very potent. They sink the viral load to very low level and they will work. Whatever is it that does not permit an individual to swallow this drug will eventually result in treatment failure. And accidental disclosure or spot disclosure, what advice do we have for you? I think the best way to avoid accidental disclosure or spot disclosure is to ensure timely disclosure. I think parents have different reasons not to want to disclose HIV status to their wards. The truth of the matter is that we really need to sit down one-on-one with the parents or the caregivers to look at advantages that accrue to themselves and to the child and to the community as a whole when the individual is aware of the reasons why he or she is swallowing antiretroviral therapy. Several studies were asking whether there is an avenue for you to get more information on how to avoid or manage accidental disclosure. Yes, there are. And I'm going to send you some references after this meeting where you can actually go and look at how to prevent the issues of accidental disclosure and what to do if for any reason there's a need to have to do on-spot disclosure. What I do, so if you have to do on-spot disclosure, it depends on the way you handle it. And the strategy that has worked for a number of people, including me, is if the parent is there on seat and the child or the adolescent is there on seat, and I have the duty to do the disclosure, I have the parent to do the disclosure by him or herself. The truth of the matter is, ask simple questions. Have you heard about it? You are asking questions, you are asking the adolescent, have you heard about HIV before? Most of them, the answer you will get is, yes, I have. Do you think your mother is living with HIV? You are most likely going to hear, no, I don't think so. If the mother has been someone that is well treated and has achieved all the goals of therapy and is looking very well, it's a very good opportunity for you to disclose to this child. I can assure you that your mother is living with HIV for many years and has been on drug, and she's fantastic, and she's not going to die of the HIV because she's on medication. And anybody that is actually HIV infected will be like your mother if they are taking HIV drug. And that is the way to go. Once you have said that, the process of disclosure to the child will become seamless. I can see Vanessa is trying to say I should hold on or I should hold it, but let's just make one last important statement here. Suppose I tell you that you are living with HIV. Me, I'm not living with HIV, but I think you are, and you are going to be like your mother if you accept to take the treatment the way your mother has been taking the treatment. The rest will be other discussions that is going to be very, very seamless. Over. Vanessa.
Yeah, thank you very much, Prof. Sorry, we are having some technical difficulties, but it's all fine now. Thank you, Prof, for those inputs. And I'm sure Dr. Asong is going to look out for you to get the links because it's quite important. And if you're just joining us, again, we are talking issues concerning disclosure. And we've just rounded off with the first case that really set the pace and has to understand that these issues are real. They are not from somewhere. We face them on a daily. Disclosure is basically telling a child or she is HIV positive, and it is a process. Why we are not going into this process, we to just see what happened, right? Wrong time and things. We had the first case that beautifully depicted for us how a child, due to non-disclosure, had issues with adherence, but was able to come out of it because of adherence and follow-up. Now we're going to move on to the second case that will be still from Cameroon for the win. Is going to also be speaking issues we have to Dr. Media. Hey, so
yes.
Thank you, Dr. Mediatrice. You can go ahead. Guys, let's be calm. Remember, again, it's real. Dr. Mediatrice, is your mic unmuted?
Yeah, thank you very much for giving me the opportunity. My network is unstable, so I can't present with my camera on. I'm Dr. Mediatrice Nindum from Cameroon, Northwest region, working as a medical doctor at Queen Baptist Hospital. Next slide. We have the case of a 13-year-old male who was born in June 2011. He was diagnosed HIV positive on May 2018 by serology. He is the first of 3 living children. Both his parents are alive and living with HIV. He lost a younger sibling to HIV, but he has 2 other siblings who are HIV negative. He enjoys a good academic performance, and presently he's going to Form 1. However, he suffers restrictions to friends and neighbors. He also has refused his enrollment to support for adolescents. He's a taxi driver, while his mother is a housewife who also runs a small provision store which is attached to their house. Next slide. Next slide, please. Dr. Vanessa, next slide. Okay, he was diagnosed HIV positive at another health facility during pediatric consultation at age 6 years. He had same-day ART initiation with Zidolam plus primoxazole, and subsequently he was referred to our hospital. He was received at our facility and registered as a transfer-in kit on 6 June 2018. The vitals and exam findings at the time were as follows. His weight was 11 kilograms, his temperature was 6 degrees Celsius, and he had pallor and purulent right ear discharged. A diagnosis of otitis media plus moderate malnutrition on a child newly diagnosed with HIV was made at this point. He received appropriate treatment plus nutrition rehabilitation. His care and follow-up, however, had by several periods of treatment interruption, but when contacted, he always claimed to have extra pills. His overall clinical state has been poor, with persistent generalized lymphadenopathy in multiple areas. Additionally, he has been diagnosed severally and managed for other ailments, including herpes zoster infection, persistent gastroenteritis, moderate acute malnutrition. Overall, he is staged at stage 3 WHO disease. Slide, please. Please, next slide. Thank you. He was diagnosed and initiated in May 2018. From May 2018 to March 2020, aged between 6 to 8 years, he was on Zidolam-Nevirapine. He had a first viral load in 2019, that was in May 2019, which was actually suppressed. However, the second viral load done in January 2020 was high. At this point, he had interrupted treatment. He became lost to follow. Our tracking efforts found him hospitalized at another health facility. We discovered adherence challenges, which were characterized by lack of parental supervision, child neglect, forgetfulness, vomiting after taking drugs, and concurrent illness. We initiated an EOC. We did an EOC with continuous therapeutic education provided, and an alarm clock was given to him. From March 2020 to October 2021, while he had attained 9 years of age, his treatment was alternating between Zidolam and Abacalam efavirenz. He had 2 viral loads within these periods, which were all high. That was in September 2020 and October 2021. He was supposed to have been disclosed at this pre-disclosed at this period, but pre-disclosure was delayed due to the mother's uncooperative attitude. His mother had refused treatment for herself and declined access to the community team to talk to herself and her child. She wanted no mention of HIV in her house. So at this point, an EAC was done with the support of a caseworker through the father, along with continuous therapeutic education, and a pillbox was given to him. From October 2021, he was 10 years old and on Abacalam DTG. He had 1 viral load done in August 2023, which was still high. Based on the persistent high viral load, he had EAC sessions extended with the father. Home visits by the doctor and OPC partner were carried out, and child support encouraged with continuous therapeutic education. All these were done at home during the visits. In February 2020, with consent and support from the father, disclosure and post-disclosure follow-up was done. After the disclosure process, we repeated his viral load in July 2024, which came out with 565 copies that was suppressed. Next slide. Slide, please. Okay, lessons learned. Our first lesson is more of a success story. The disclosure and proper post-disclosure follow-up, plus the relentless and concerted efforts of the clinical and the community teams while overcoming the mother's resistance. While overcoming his mother's resistance was the driving force to achieving improved adherence in this child and consequently viral suppression. This also succeeded in bringing back to care his defiant mother who had stopped treatment. Our first lesson is that timely disclosure and post-disclosure follow-up can help overcome challenges to adherence in children and adolescents, thus improve clinical outcomes. Parental or family support is an essential aspect of pediatric HIV care. Lastly, we learned that collaborative efforts of care involving the clinical as well as the community team is vital towards achieving success in pediatric HIV treatment and care. Next slide. Next slide, please. These are the questions that I have for the experts. With undisclosed inquisitive children, adolescents whose parents have refused disclosure, what steps do we take given the risk of treatment interruption? To the read, in case of parents' restriction to care in children, what is the way forward? And lastly, should treatment regimens be changed systematically for children with persistent high viral loads? even if adherence issues have not yet been fully addressed. Thank you.
Thank you, Dr. Mediatrice, for taking us through another great case. I am going to quickly hand over the floor to Dr. Robina to bring her input, and then Prof. Alani. Dr. Robina, you have the floor. Thank you.
Yeah, thank you very much, Dr. Vanessa. Thank you very much, the team Cameroon, for managing this case. My input in regard to the question, first and foremost, I really want to appreciate you for all the effort done to make sure that you bring on board the parents. But also in regard to this first question, with undisclosed inquisitive children or adolescents whose parents have refused to disclose, what steps do we take given the risk of treatment interruption? So first and foremost, I usually, when the child or an adolescent starts to ask questions in regard to HIV, that is an indication somewhere there is accidental disclosure that happened, and the child is just on the nose, like the adolescent wants to confirm, is it true? Is this thing that I'm suspicious of true? So this is the step where you actually have to come up as a counselor, as a managing clinician, as long as this adolescent starts asking questions, to now start posing, to start giving information, start showing her, like bringing the caretakers on board, assessing for their readiness, but also assessing the child's readiness to disclosure, and straight away start the process of disclosure. As you start the process, then the caretakers will be on board. Secondly, in most cases, parents would have fears, like they have fears, and those fears are just, they are just there, like they just don't want to be blamed. They're like, how do I start it? So it's upon us, the health workers, to actually help these parents or caretakers to overcome those fears and stand firm to start the process. But we can also do what we call assisted disclosure and help them in the process of disclosure. The second question, in the case of parent restriction to care in children, what is the way forward? So this is where I like the first case where it had multiple caregivers. So here the parent, who is the primary caregiver to an adolescent, is having restrictions. But then this is where you actually have to go an extra mile of looking for a secondary caregiver who you can empower with the treatment literacy to go ahead and support the adolescent for purposes of maintaining this adolescent on care and welfare suppressed. So here you are not restricted. But also in the processes, like for this case, in the processes where you are actually trying to navigate how to go into the community, and remember you have to go to the community when you have been given access by the parents. So in that regard, you can be doing what we call facility aided support. You are supporting the adolescent from the facility as you sort out the community. You can call up parents meetings at the facility. In case they do not want you to visit them in the communities, you can call them at the facility, and then you offer them literacy, because generally they are denying because they are not empowered. They don't know the effect. So this is what you could do to actually come out with this. Then the last question, should the treatment regimen be changed systemically for children with persistent high viral load, even if adherence issues have not been fully addressed? I would say no. even though you changed the treatment regimen for an adolescent or for anyone on HIV care and treatment and gave a very fully potent regimen, and you left the adherence issues unhandled, you are still doing nothing. So the ideal is if you think that the drug is not potent enough and you'd want to change, but go ahead and address the adherence barriers. It's upon addressing the adherence barriers very well that will help that fully potent regimen to actually help suppress the virus. But if you do not address the barriers, even that potent regimen will end up getting resistance. So I just argue that we address the adherence barriers as far as possible so that we can address. As I end up conclude, Dr. Vanessa, I just want to emphasize this fact that in disclosure, once we disclose, let us be aware of the consequences that will come in later. Even though the disclosure was very good, but there are other behaviors that may come in, and then it's upon us health workers to be able to support those behaviors. Thank you very much. Over to you, Dr.
Thank you very much, Dr. Robina. I will hand over to Prof. Alani. Thank you.
Thank you very much. I think I should just start from the third question. Looking at it from another angle from what the other expert has just said. There are situations where you want to change, and there are situations where you do not want to change until you have tried the same drug that the patient is currently on. The way you did it in this index case is a situation where you should not bother to change until you have an assurance that adherence is 100% assured. Now, when you see viral load, the way it is in this patient, 124,000, the truth of the matter, that is a heavy viremia. The truth of the matter is that viruses who have mutated and have achieved what they call drug-resistant mutation, they don't replicate very fast. When an individual is no longer responding to your current regimen, and you are now seeing the viral load as 3,000, 5,000, 4,000, 3,000 for over a period of time, those are viruses that we say are replication incompetent. And the truth is that they have accumulated a lot of resistant mutations. Resistant viruses or mutated viruses, we say they are wounded viruses and they lack the capacity to replicate very fast. So you see viral load usually below 10,000. When you see an individual with heavy viremia, those are wild type viruses. If you take samples of such patients for what we call resistant testing, the result will be sent to you as all the viruses are sensitive to your drug. So you can look at the value or the level of the viremia to also take a biological decision that this is not for me to change. If you see this, your patient that have been on and off treatment for long, and the viral load is in the region of 3,000, 4,000, 5,000, 6,000, 5,000, changing might be advisable. Because if you still continue on your previous regimen, it's like you are leaving this individual on a failed regimen. So just look at the viremia. Viremia, 30,000, 50,000, 100,000, 200,000. They are wild type viruses and there's no use you changing it. But the logic of the former expert is also very correct. You can actually wait. Once you see that this individual has been off drug and he's now coming back to care. You want to assure assurance, and then be sure that the drug, the viral load is not coming down. Even when you are assured of adherence, then you can change. But look, if you are a good clinician in HIV medicine, you can look at the level of the viremia and take a decision. I'm changing, I'm not changing. That's another angle. For the other previous number one, number two questions, I think the answer to all these questions put together is that the parents or the caregiver needs to understand something, that honesty is the best policy. It is good that they let their words know the truth from them so that their words can trust them. Whatever they say thereafter, the trust is key. When you are afraid of telling your child the truth, is a big problem. And that truth they don't want to tell is the reason why they don't want to declare on time. So when we are doing our counseling to the parents, our issue is actually not the child. Our issue is the parent. What to say to the parent? Preaching the fact that let's just be honest with children. When they see through you that you are telling them the truth, it's very easy for them to agree with you when you want to tell that they are living with HIV and this is the way to go about it. Over.
Thank you very much, Prof. I think key words, preach, and preach the right thing to your children, or encourage your parents to preach and to tell the children the truth. Thank you very much to both experts for responding to that case. And if you're just joining us again, we are here on a Patter Reel, and it's getting very real. And of course, we are reviewing cases. And today our theme is around disclosure. We've had two wonderful cases, and we are moving on to a great case as well. So I'm going to be inviting Dr. Susan to walk us through this presentation. Dr. Susan, thank you. You have the floor.
Hello?
Yes, Dr. Susan, we can hear you. You can go ahead.
Okay, thank you. My name is Dr. Susan Joseph Mosh, working at the Amana Hospital. It is in Dar es Salaam in Tanzania as well. I'm going to present a case of a young girl of 16 years old, female, the youngest one of the 3 children, and the only one living with HIV in her family. At the age of 7 years old, was diagnosed with HIV, but her status was kept as a secret by her mother due to fear of stigma. Her mother was also living with HIV, was the child primary caregiver and supporting system. However, she passed away in 2017. Her father is a small-scale farmer, and he was unaware of his status of the daughter and her wife until after the mother's passing. At the present, the child lives with her sister, who is primary caregiver. Her father is married to another woman. They do not have they do their best to attend the Saturday clinics and support groups, and the health facility plays a crucial follow-ups. She is the secondary school, but unfortunately is not performing well. Another slide. On clinical presentation, she was diagnosed on HIV on May 2021, May 21, 2015, when she was admitted at Amana Hospital with history of intermittent fever, significant weight loss, cough, and oral thrush. The initial impression was pneumonia to rule out PTB and HIV. She weighs 14.5 kg, height 109 centimeter, temperature of 36, blood pressure was 90 millimeter of mercury. There were some investigation which was done. HIV test, which will reveal positive. TB screening by using Scott chart, it was negative. Sputum for FB was negative. The CD4 count was 96 cubic per millimeter. Hemoglobin of 8.9 gram per deciliter. Hepatitis B was negative. ALT was normal. Creatinine was 1.04 milligram per deciliter. Next slide, please. Clinical evaluation and treatment history. On May 2015, she was the first time to be diagnosed with HIV while he was admitted. June 2015, the regime had started, which was the T3TC and nevirapine, and is supported by her mother. November 2016 up to April 2019 was switched from the T3TC and nevirapine to Abacavir 3TC and efavirenz. Her viral load was keeping on changing. It was 57, 60, another year it was target not detected, and then 26 copies millimeter respectively. After her mother passing when the child was 10 years in 2018, full disclosure was done. However, the family had misled her by saying everyone had HIV in the family, which was not true. So it causes depression and led her to discontinue treatment for a year. In May 2023 to May 2024, she stopped ART for a year due to denial and question asking herself about her condition. Also was presenting with cough, fever, general body rashes, and loss of weight. March 2020 up to June 2024 the regime was switched to tenofovir, lamivudine, and dolutegravir. Also, viral was still swinging from target not detected to 6,130, then 103, then 141. In June this year, it was 97,100 copies per mil, respectively. In June 2024, adherence counseling was initiated properly. Counseling session helped her to restart the treatment, and the current regime is being monitored clearly. Another slide, please. Another slide. Another slide. Lesson learned from this case. Healthcare providers should take time and be patient when attending to adolescents, probing thoroughly together to get clear information while maintaining confidentiality and providing youth-friendly services in their facilities. Number two, parents and caregivers should closely follow up with their children, be friendly and supportive, and consider using direct observation therapy approach for early disclosure treatment. Number three, adolescents should be encouraged to be transparent with their healthcare provider to improve adherence to their ARVs so as to keep their health good. Next slide, please. I have questions for the expert panels. Question number one, how can we effectively address denial and depression in children and adolescents living with HIV, particularly when they have been misled about their status, like this one? Question number two, how does the timing of HIV disclosure impact treatment adherence, and what can be done to address mistrust in the treatment process that arises when the disclosure process is not followed? Number three, what are the best practices for re-engaging children and adolescents with HIV treatment after a long period of non-adherence? Thanks for listening.
Thank you very much, Dr. Susan. I am going to again call on Dr. Filuka, Prof. Alani to bring in their thoughts at this point. Dr. Filuka, you have the floor. Thank you.
Thank you.
Thank you very much. Thank you, Dr. Susan, for this case, and thank you for managing this patient and reaching to the best outcome. So with the first question, the denial and depression in children, we often encourage the different ways of doing that. When we start with the disclosure process, we encourage their reassurance, and we can pair these children with the experts, the older clients, like older adolescents, for them to give them assurance and support them with the questions, especially the ones who are between the age of 10 to 14. And you can pair them with the ones who are age 15 to 16 who are experts, and they can support them, because at that early adolescence, they have so many questions and they need to be answered in a safe way, and giving them that opportunity to be in a group and express their feelings and emotions, and that's how we can really reach and be able to alleviate their symptoms. Even the denial, once they connect with one another, it's easier for them to accept and also start self-managing themselves. Another thing is, if the depression is worse enough, is more severe, then you rather the health provider to sit with the child, or even referring to more specialized units to help and treat with that depression. But also further to this is involve the parents as well, because looking at the parents and caregiver, these are the most important, because they spend more time with the child. So it's important to give them psychoeducate and give them knowledge and skills on how they can support these children while at home. Also, the second question is about the disclosure, the timing of disclosure and the impact the treatment. That's why we are insisting early to disclose, as we know between the age of 10, the children are starting questioning what really happened, and they start getting that understanding where their situation, and learning where they are and who they really are in that moment. So when you start early at the age of 7 and 8 to slowly partially disclose about their illness, when they reach there, when they have questions, and when you also support their parents to disclose this HIV status, it really impacts on the treatment adherence. But the late disclosure, like at age of 14 or after that, you create or you bring up a lot of emotions and depression and stress, and around they may have so many questions around it and denial. So that may impact on the depression, on adherence, and may even have a decision not to take the medication, and tends to end up with mistrust. With the best practice of re-engaging is pairing with the other children, especially the older ones from age of 10 to 24, pair with the ones that they can support one another in, so that they can re-engage and start taking medication. And also constant doing this enhanced adherence counseling, and also supporting them, reassurance, giving them reassurance while they are taking this medication. Yes. Over to Professor.
Hello, Prof. You can go ahead. Thank you.
Thank you very much. I think we have to understand, addressing the first question, that today, issue of mental state or mental health status of our children is becoming a big thing in HIV medicine practice. And majority of children or adolescents who actually now do not adhere or become rebellious with their treatment are the people who are not declared to at the appropriate time. These are the type of adolescents that in fact develop depression. And this is why today, in most pediatric HIV clinic, what we are now preaching is the direct application or implementation of mental state assessments of all children. And there are validated tools that we are now using to train many of our caregivers. And these tools are applied to the children, and there's a way to score these tools. Depending on the score, you probably will be able to give what we call a prepared counseling way to ensure that this individual does not progress in the depression. But if the score is such that this individual has actually gone far, then of course you've got to refer this individual to the specialist, and we mean the psychiatrist. And so we really want to take the burden away from the psychiatrist, because we have large number of patients and we have very few number of psychiatrists, that can help us. That is why it is important that we have access to these mental health status tools, and we are able to assess all our children. And the number of them that are actually developing depressive state, we should be able to handle them in our clinic, giving what is being prepared to us as how to counsel those children, and those that are actually having a score that we cannot handle in the clinic are referred. So that actually answers your question number 1 and 2, because the way to ensure that an adolescent does not get accidental disclosure, or you do not become an adolescent before you are disclosed or you have developed a mental state or a depressive or an anxiety state, is to ensure appropriate disclosure at the right time. And that right time is anything between age 10 years and 11 years. When it's getting to 12, 13, it's already getting late, and that individual is already formed, very fully formed, and its state of depression is already coming. You really want to know why he's swallowing drugs every day. So we must ensure that we do timely disclosure. What are the best practices for re-engaging children and adolescents with HIV treatment after a long period of non-adherence? There are actually tools, to do this, particularly for the adolescents. What people are doing in most places is Operation Triple Z Club. What we are presently doing in adolescent is pairing individual, like the first case where you have a champion, a viral load champion, it's just deliberately pairing one good viral load champion with 5 or 4 unsuppressed individuals, and using what we now have as your WhatsApp messages, whatever that you are social media. This actually helps when you do peer-to-peer navigation, peer-to-peer counseling. This actually works. We have actually demonstrated this in the University of Ibadan about 5 years ago. We actually repeated the same feat in 6 other universities in Nigeria. And of course, we are having another NIH grant now to see how we can use a child that is actually doing very well to navigate other children that are not doing very well in a larger scale in the country. So what we are preaching is that we may have to use children who are doing well to navigate children who are probably not doing well among the adolescent group. Over.
Thank you very much, Prof. Alani. We realize that there's a lot to learn, there's a lot to take home, there is a lot to savor, and even when you thought you knew, you'd keep learning new things. Thank you. That's the beauty of the reels, because when it gets real, you get real solutions then. Thank you very much. Now I'm just going to give each of our presenters just a split second to say just one key takeaway that they have that they're going to use in the management of their cases. So rapidly, I'm going to start with you, Dr. Bertrand. You're just going to say one key thing that you've taken away and you're going to use. Thank you, and over.
Thank you very much. One key thing that I can taken away from this meeting is that when we approach children who have disclosure issues, it's good to look at it holistically. Let's not look at it just with regards to the medications. Let's not look at it just with regards to the caregiver's attitude, but also consider how ready the child is at a certain point in time before you begin the process of disclosure. So systematic disclosure is very important regardless of our context or regardless of our facility. Thank you.
Thank you very much, Dr. Asom, for that. And I'm going to rapidly move to Dr. Mediatrice. Just one thing very quickly. I know that we have gone ahead of time, but you bear with us. Thank you. Dr. Mediatrice, over.
Thank you. One thing I've learned here briefly is that in dealing with children, you have to focus on the children holistically, even without the parents' consent, like when they are already getting to adolescence. You focus on the child and look at the child holistically to be able to offer care with the utmost intention being to have positive outcomes in the child. Thank you.
Thank you very much, Dr. Mediatrice. And lastly, we'll get from Dr. Susan one key takeaway from this session. Is Dr. Susan still there? I guess not. Okay, so thank you. These are the key feedbacks we've had from our dear presenters. Just want to encourage all of us that we are all frontliners and we face these challenges on a daily. So always make it a point of view to join us so that we can discuss the real cases and find solutions together. We want to thank our experts for all their input. They have been so valuable. I wish we had more time to listen to your beautiful inputs and contributions. But however, I think all of the resources that have been mentioned, we have a PATA hub that is packed with all of this information. Shortly after this meeting, you should watch your chat box. A link is going to be shared with you. Through that link, you can connect to the PATA hub and get more information around disclosure and many other things as a frontline healthcare provider to help you provide optimal services to children and adolescents. Also, we would like to hear from you. We've had the opportunity to hear from our presenters what has been their key takeaway. And so we are also going to be sending you a survey. We just want to know what you feel about this sessions and what you think we can do better. And of course, we need you to tell us what you would like to hear in subsequent PATA Real sessions. So thank you very much. PATA Real comes up once every quarter. It was really a pleasure to have connected with everybody and looking forward to see many more people in the next session. Thank you and bye.